screen. All right, so I think everyone should be able to see my screen now. So this is introducing people to the concept of neuropalliative care. It's actually good timing. We have a new grant with the Parkinson's Foundation, and we have a grant actually under review that would be expanding it to work with people in Italy. So we will see what happens, but we are working on doing this internationally. And you can see here, and I will talk a little bit more about this, is that I am president of a new society, the International Neuropalliative Care Society. So this is definitely an issue that affects people around the world. And I'm hopeful, and I'm glad actually to see people from all across the world to learn about this important subject. So disclosures, I will just say that I have been lucky enough to receive quite a number of grants related to palliative care, and that there finally is interest in moving this work forward. So a lot of important things are happening, and I'll share some of the research that we have done and some of the research that we are going to be doing to make palliative care more readily available to people who need it. So we'll start by defining just these terms, palliative care and neuropalliative care. I think there are probably an equal number of misconceptions about palliative care as there are correct facts that are out there. We'll talk about why neuropalliative care is so important for people living with neurological illness, including and maybe even particularly Parkinson's disease and related disorders. We'll talk about some of the basic components of neuropalliative care, and part of talking about that is not simply talking about it in terms of what physicians and nurses and healthcare providers need to know, but intentionally talking about it in terms of what people living with Parkinson's and their families need to know. One of the questions that I've gotten a lot, and I pay a lot of attention to, is how do I get this kind of care where I live? And part of that, if you're lucky enough to be in a place where there's a Parkinson's neuropalliative care team, great. But if you're not in such a place, there are still ways that you can have a checklist, that you can ask the right questions, and that you can advocate to get this type of care for yourself and your loved ones. That's very important. And lastly is connecting neuropalliative care potentially to your values as an advocate. And so whether you are running a support group, whether you're advocating for yourself or a loved one, whether you are doing political advocacy to try to get research money or change the way care is provided, I hope at the end of the lecture that you would think about palliative care in this framework as something that's important to how you will advocate for the Parkinson's community. So to define neuropalliative care, just in a quick sentence, is that palliative care at its essence is about living as long as possible for living as well as possible for as long as possible. And I would stress and even underline the word living, which is different than surviving. So when we talk about living, we are talking about what does it mean to be fully alive, to have joy in our life, to have connection, to have meaning, to have a sense of purpose, to feel like we count and that we matter. And palliative care is about helping people to live right up until the time that they die. That is what palliative care is about. The World Health Organization recently updated their definition of palliative care. And in part, this was updated because historically, palliative care has been associated with hospice and end-of-life care, and it's been associated with cancer. And as the field of palliative care has developed, that's expanded and that's changed quite a bit. So one part of palliative care is that it enhances quality of life, and there's two sides of this. Part of helping people improve quality of life is to reduce suffering, to reduce part of what we would call the total pain of serious illness, which includes not just medical symptoms and physical pain, but also emotional pain, spiritual distress, practical matters, social isolation. And part of it, and this is something I'm focusing a lot on right now, is on the positive side of quality of life. So how do we continue to allow people to bring joy and meaning and connections into their life? I don't know how many people here have taken part in research studies, but a lot of research studies, we ask people questions about quality of life, and they're all measured from 0 to what I would call negative crap. So we're measuring things on a pretty negative scale. We're measuring things in terms of deficits, and nobody wakes up in the morning, hoping to get to zero. We don't wake up in the morning hoping to have no pain. Maybe we do, hoping to have, no depression. But I think we also wake up in the morning hoping to find pleasure, hoping to have happiness, hoping to have joy. And as I think about these things and write about these things, I think, joy in particular becomes more important, not less important, when we're dealing with a serious illness or dealing with a serious situation. One of the things that happened over the last year with COVID that was interesting is that in social media, mentions of joy increased after the beginning of COVID. And I think that's because people naturally recognized and gravitated to the importance of joy in their life and the need for joy to make it through a tough time. And so this is absolutely true for people living with a serious illness. Palliative care offers support to help patients or people live as actively as possible. And sometimes because of disability, this might change. And so examples from my clinic could include modifying an RV so that people continue to travel. Maybe somebody who used to like hiking and can no longer hike the way they did can still make time to go into the mountains and to enjoy being in scenery that's important and meaningful to them. So whatever people's limitations are, that we want to go right up into those limitations to live life as fully as possible. Palliative care recognizes that Parkinson's disease doesn't just affect one person. It affects a spouse, it affects a family, it affects a community. And that is part of the palliative care package that we really want to address and recognize and support family members as well as the patient. We provide relief from pain and other difficult and distressing symptoms. That's something that a lot of people know about with palliative care. What's not as talked about is that in Parkinson's disease, things like pain are actually quite common and often fall between the cracks of our healthcare system. And that was actually one of my early motivators for doing palliative care, was so that we can do a better job of treating things like depression and constipation and pain. We affirm life and regard dying as a normal process. I don't know if the same is true in Italy. When I speak in the United States, I often joke that the United States healthcare system is one of the few healthcare systems in the world that feels that death is optional. Maybe the Italian healthcare system is similar, but I think a lot of times when people are in the intensive care unit or in the hospital, we talk about everything, but we don't talk about dying. And it's almost like we have this belief that if we do enough chemotherapy or enough chest compressions or enough dialysis, you don't have to die. But unfortunately, we live in a world where death is a reality, and that Parkinson's is a progressive illness. And so we don't have a choice about if we die. We don't really have that much of a choice of when we die, but we do have some choice about how we die. And for most people, we can even, take a little show of hands or a vote, but I think most people would rather die at home, surrounded by loved ones, than to die in a hospital or an intensive care unit. And we can achieve that by palliative care. We address psychosocial and spiritual issues. I think this is important, that we talk a lot about things like anxiety and depression that are psychiatric disorders. But with an illness like Parkinson's disease, there are difficult but normal emotions that come up. So people may feel grief, which is a sense of sadness for things that they've lost in their life. Patients and caregivers may feel guilty. People may feel lonely. So these are normal parts of the process, and the way we support these things is not by pathologizing them and putting people on Prozac, but to provide support and talk about them as normal parts of the process. Lastly, and I think very importantly, is that palliative care is applicable and actually should be done early in the course of an illness. When people get their diagnosis of Parkinson's disease, that's oftentimes a very stressful time in their life. They have a lot of needs, emotional needs, they need planning for the future. And I can't tell you how many times people feel kind of abandoned and left on their own after the time of diagnosis, and that it takes them years to figure out what's going on. And so as we're thinking about palliative care for particularly an illness like Parkinson's, we need to think about how do we start this at the time of diagnosis and keep this throughout the whole course of the illness. The term palliative care can be confusing because we use it in a few different ways. The first way, and I think in some ways the most important, is thinking about palliative care as an approach and a philosophy of care. And by this, I mean that anybody on the team, a neurologist, a palliative medicine doctor, a nurse, can and should take a palliative care approach or a person centered approach to how they care for people. Palliative care can also be used to refer to certain skills. For instance, how we talk about serious illnesses, how we care for people at the end of life, how we manage pain. Palliative care is a medical specialty, and I think this is where it often gets confusing, is that people feel like they may have to go to a palliative care clinic or see a palliative medicine specialist to get palliative care, and that's not true. So neurologists can and should do some of these things that we are talking about. And lastly, palliative care can be thought about as a public health goal. So as we're thinking about really the goals of medicine, some of the things that are really important are that people can die comfortably and with dignity, that people who have illnesses that we can't cure get the care that they deserve. And so we think about palliative care from individual person to the biggest population picture. Kirk Hall, who is a patient with Parkinson's, who I've worked with, wrote a wonderful paper on palliative care from a patient perspective. And one of the things that he illuminated me to is thinking about palliative care as a public health goal. And so, if our goal is to provide the best palliative care possible to everybody with Parkinson's, we need this kind of three-legged stool. So, we need palliative care specialists who know and understand Parkinson's and are willing to care for people with Parkinson's. We need community and disease support organizations who understand palliative care and can provide support groups that support our goals. And then, lastly, and I think one of the most important legs, is that we need non palliative care specialists like neurologists who understand palliative care, who can refer people for palliative care. But there's a lot of the palliative care approach that will not and cannot be done by palliative care specialists. As we're thinking about this, palliative care is not, it's not an either or kind of a thing. So we don't need to get rid of everything that we used to do and start doing palliative care. It really complements our standard care. So our current model for Parkinson's, what I would call a chronic care model, which we do well at, is that we focus on disease-related medical symptoms like tremor. We focus on improving physical health and exercise. We work on prolonging life. We're focused on the patient. We sometimes will use a team. And then palliative care adds another dimension to this. So it complements chronic care. We focus on the total pain of serious illness, meaning that we go beyond just physical symptoms to talk about emotional, psychosocial, spiritual. We also go beyond being focused simply on physical health and function to talk about overall well-being and how can we still have a great quality of life even if we have a serious illness. We move beyond the simple, or I would say simplistic goal of prolonging life to certainly affirm and value life, but at the same time planning for reality, planning for decline of health and planning for the end of life. We don't just focus on the patient, but also on family. And because palliative care is so comprehensive, we almost always will need a team to be able to do it well. Just to be clear, and I think some of these terms may be different in Italy, so we can talk about this. So in the United States, at least, hospice refers to end-of-life palliative care. And I know in different countries, hospice and palliative care, those terms are used in different ways. So we may talk about that more later. But palliative care is not just for people at the end of life, is the main point there. Palliative care is not euthanasia or death squads. And in fact, the palliative care community is really split around whether to support or not support medical aid in dying. Palliative care is not giving up on patients or doing nothing. And I think some of this comes from language that doctors use, sometimes unintentionally. A lot of times when a doctor will say, "Do you want everything done?" they are implying that giving chest compressions, being on a ventilator, doing dialysis is everything. But I think the real question is, do you want everything done to survive? Would you want everything done to be as comfortable as possible? Do you want everything done to spend as much time with your family and out of the hospital? So we really need to think about goals. But with palliative care and with our clinic, we absolutely do a lot more than nothing. In fact, we will spend 2 hours sometimes in a single visit trying to do everything we can. We provide very aggressive care just with different goals in mind. So our goals are really to live fully rather than to survive as long as possible. Palliative care is not just for people who are dying or with cancer, and palliative care is not just for palliative care specialists. It's an approach that anybody can and should be a part of. Neuropalliative care is a newer term, and it specifically refers to the fact that people living with neurologic illness like Parkinson's disease have very different and unique needs compared to people with cancer or other medical illnesses. And part of the reason why myself and others are pushing for this term neuropalliative care is that we really need systems of palliative care that are custom fit for people with Parkinson's disease, that we cannot simply send people with Parkinson's to the cancer center to join the cancer center supportive or palliative care clinic. And so if we are thinking about a recipe for how do we do this, we need people who really understand neurologic conditions. And that's often not palliative medicine doctors because their training is in internal medicine. It means that neurologists have to be competent with the palliative care approach. We need to think about, and this gets into the advocacy piece, what are the teams and the systems and the institutional support that we need to make this work. We need to communicate well between members of the team, and I think this is where oftentimes things fall apart, and I'm sure a lot of people on the call have seen this. I can't tell you how many times I've been asked the question, why don't my doctors talk to each other? So we really need to make sure that we have this well coordinated. How do we bring up palliative care with physicians? For the support group talk, I'll let you know that there's been a number of studies that show that patients are more likely to go to a supportive care than a palliative care clinic. So the words that people use matter. And it's important that if you are requesting palliative care, so you see this talk and you are interested in it, you might ask your healthcare provider about it, and very often the answer you're going to get is that, oh, I don't think it's time for that, or we're not ready for palliative care, because physicians have the same misperceptions that the public does when it comes to palliative care. So these are a few of the phrases that may be helpful, and just like we recommend for physicians not to use the word palliative care, you can avoid the word palliative care with doctors. So I think I and my family could benefit from an extra layer of support. I would like some help talking about the big picture and developing a roadmap. I'm struggling with grief or pain or guilt, and I believe a palliative specialist may help. So these are ways that you can get the care you need without having a blanket refusal from your doctor or your healthcare provider. So then moving on to the second part of the talk of why is neuropalliative care essential? This is a quote from Melina Summerall, who is a care partner. She's an advocate. She has a background in healthcare and education psychology. And she says here, I see a relief on the faces of patients and care partners when they realize what is available to them through palliative care. They know they have a team to help them. They feel their symptoms are better addressed and that their concerns are heard. So this is what palliative care looks like in the real world. And one of the things that Melina is doing right now, which I think is very cool, is she is a caregiver navigator. So she works in the clinic I started in Colorado, and she works directly with other care partners to share her wisdom and her experiences with them. When I talk to people in clinic who have serious illnesses, including Parkinson's, these are the things that I hear that really matter to people. So people, probably even number one, this may be in order, is family. So people want to spend time with family. People need to know that their family is going to be supported no matter what happens in the future. Integrity and dignity. So people need to feel that they're still an asset to the world, that they're not a burden, that they will have control and choices as their illness progresses and as things move forward. People want a roadmap for the future. Simply being told everybody is different is not very helpful. We really need a more concrete roadmap to be able to know where you are right now and what's ahead. Symptom control is important, and not just tremor, and in fact, some of the things that I think are more important often than tremor are things like pain, depression, fatigue, constipation that really impact people's quality of life. And the last thing I put here, and I have evidence to support this now, is joy. As part of a study that we did with 210 people with Parkinson's, when we asked people what was the most important things for them in the last 3 days, over half of what they mentioned was positive. It was activities, it was being with family, it was connection, love, rituals, being part of their religious circle. And so as a healthcare community, we need to start thinking about and talking about joy and other positive symptoms as we are moving forward. These are some of the palliative care issues that we see in neurology and also that we see in um, Parkinson's. There are burdensome non-motor features like pain and fatigue, demoralization, which means a sense of hopelessness or a sense of giving up, and other spiritual challenges. Sometimes people ask the question, why did God do this to me? Why is this happening to me? Very high caregiver demands and burden. This is a big difference, I think, from cancer in that Parkinson's disease is years. So Parkinson's is a marathon compared to cancer. And there's also both physical and cognitive changes, which I think makes things harder for care partners. There's a lot of variability in the way Parkinson's progresses that can be difficult for doctors. It's also difficult for people to live with, trying to live with uncertainty. End of life care is important in the United States, and I think actually worldwide, Parkinson's is one of the top 20 leading causes of death. In the United States, it's the 14th leading cause of death. So we need to do a better job with end of life care. In the United States, actually, people with Parkinson's are more likely to die in a hospital than they are to die at home. And I think that really reflects how we are not doing a good job with end of life care for Parkinson's. And then the last thing is that even after somebody with Parkinson's dies, that care partners have high rates of grief and complex bereavement. And I think part of this comes about from losing the person that they love 1 inch at a time or 1 day at a time. And so we need to address that early, and we need to plan to continue to support people even after their loved one passes away. We also know that there are significant gaps in our models of care. We don't do a very good job when it comes to recognizing and managing things like pain and depression. In fact, we know that about half of the time these things fall between the cracks of our medical system. We are not doing a good job with advanced care planning. So filling out paperwork of who we would want to be our voice in the event that we can't speak for ourselves, putting in writing what kind of care we want and don't want. As I mentioned, there's very high rates of people dying in hospitals and nursing homes, which I think is avoidable if we had better palliative care. We are not thinking about things systematically when it comes to psychosocial and spiritual issues. We don't have a checklist that we're asking people, are you experiencing grief or guilt, even though these things are predictable. We are not systematically assessing care partners and family members about how they're doing, which I think is a large missed opportunity. There are institutional barriers. I'm very interested to hear what they are in Italy, but in the United States, for example, you cannot get hospice at the same time you're getting physical therapy. And while this may make sense for somebody with cancer, it does not make sense for somebody with Parkinson's who can benefit from physical therapy even up until the time that they die. And lastly, we are not doing a good job, although we are trying to change this, in educating neurologists and palliative medicine specialists on neuropalliative care. Palliative medicine is, in my opinion, the future of medicine. So a lot of times when you hear talks about the future of medicine, we talk about robots and we talk about genes and stem cells. But if you look at how medicine has changed in the last 10 to 20 years, one of the things that's really apparent is that it is becoming increasingly patient and person-centered, meaning that it is no longer focused on what's best for the doctor or what's best for the disease, but what's best for the person living with the disease. And as I mentioned earlier, palliative care is essential to achieving the goals of medicine. So it's essential to relieving pain and suffering. It's essential to curing people and caring for those who cannot be cured in the pursuit of a peaceful death. And it's also important with what's called medicine's quadruple aim, which means that we want patients to have the best experience possible and to have high satisfaction with the care that they're getting. We want to reduce healthcare costs, and palliative care actually does that by keeping people from dying in the hospital. We want to improve population health. So we want to, again, think about how do we help people across the spectrum, not just individuals. And then the last thing, and this is particularly important in neurology, is that a lot of physicians and healthcare providers are experiencing burnout. And I think, for myself, but for other people I work with, that palliative care really increases joy in practice and allows people to get them back into the kind of medicine that brought them into medicine in the first place. Doctors did not get into medicine to fill out paperwork, to do billing. to try to see 18 patients in half a day. People got into medicine because they wanted to connect to others, because they want to be kind, they want to help suffering, and palliative care allows them to get back into that. We did a project 6 years ago now was when we started, to try to prove that palliative care is better for most people with Parkinson's than our standard care. And this is the model of standard care at the time we started the grant, which is that neurologists help people with their motor symptoms and PD medications. Primary care providers help with other things like high blood pressure and diabetes. Nobody is really helping the caregiver. And it's kind of up to the patient and the caregiver to figure out on their own advanced directives, spiritual needs, caregiver support. And so what we saw at the time was that if someone was seeing a neurologist, they had good motor symptom control, they had so-so non-motor symptom control, and that we were doing a pretty poor job when it came to other things that we knew were important to people living with Parkinson's, like psychosocial and spiritual support. So this is the model of care that we tested, was that we would have our neurologists doing what they were doing, primary care providers doing what they're doing, and then we add in a team to talk about these other things. So we add in a team to support the care partner, to talk about non-motor symptoms, prognosis, spiritual well-being, grief. And our hypothesis was that the addition of this team would result in better patient quality of life, better care partner quality of life, better symptom control, better advanced care planning. And fortunately, but not too surprisingly to us, that is in fact what we found. And so if you can see the arrow here, this is quality of life, and people getting usual care had had worse quality of life starting at 3 months into the study, and they continue to have worse quality of life throughout. In this case, blue is palliative care and usual care, red is usual care, and the lower you are, the worse the quality of life. This is for patients. This is a measure of caregiver burden, in which case higher is worse. And in this case, people in the usual care had increasing caregiver burden over time, whereas with palliative care, it improved over time. And you can see actually at 12 months at the end of the study, it was continuing to improve. And that makes sense because palliative care, and we found this in our models, actually is more beneficial the more severe the illness the patient has. And so it would be expected to become increasingly important the more people's illness progresses. Other things actually that, just to mention from the study is that people in palliative care, they felt seen and heard, they felt like they had a roadmap, they completed advanced care plans, they had better symptom control, caregivers had better anxiety, better spiritual well-being. So it was really uniformly, I think, a very convincing win, showing that palliative care for people, at least with advanced Parkinson's and high palliative care needs, do better when they get palliative care than usual care. Some of the questions that came up from that study and others is, when should palliative care start for people with Parkinson's? Who should get it? And also a practical one, can we afford to do palliative care? Can we afford to have this type of team-based care for everybody? So the first answer is, now is the time to think about palliative care. So this is a figure I made for a chapter because I couldn't find a figure that actually showed this. But if you're looking at palliative care needs, at the time of diagnosis is actually a time where palliative care needs increase. And then over the course of the illness, if there's loss of ability to drive, needing help with dressing, more advanced disease, these are all times where palliative care needs can increase further. But we really need to always think about palliative care, and even when things are going well, that we can do things to be prepared for the future. Everybody deserves a palliative care approach. So some of the basics here is that we want to provide the diagnosis with skill and compassion. We want to address emotional and spiritual concerns when they arise. We want to support family members, address non-motor symptoms, provide a roadmap for people moving forward. So it's not a question of who needs it, but really how do we do it? There are some indications for specialist palliative care. So if somebody is nearing the end of their life, if people have significant distress, significant concerns or worries, there may be a need to bring in a palliative care specialist, but everybody deserves a palliative care approach. So those are two separate things, but they are related. To implement palliative care, I believe can be done. And in fact, we are starting a study right now that's setting out to prove that it can be done and that our healthcare systems not only can afford it, I think they can't afford to not do it. Part of why I say that is that primary palliative care, so neurologists taking ownership of this issue and doing a better job with palliative care issues, is the foundation. So we do not need to hire thousands of new palliative specialists to do this. We need to train neurologists to incorporate this into their practice. And I know that we can do this because neurologists have done way more complicated things. Neurologists have learned how to do deep brain stimulation. Palliative care is much simpler than that. We've got this. We can do this. Community and advocacy groups are going to be essential. And part of why I'm really happy to do this talk is that when I'm thinking about palliative care, I'm thinking about this in terms of a culture change. So this is changing the culture of medicine. And I believe that what's going to drive this culture change is grassroots support. So it's going to be patients and care partners and family members asking and demanding that they get this type of care. I believe that's going to drive it much faster than physicians or people like myself trying to get doctors to do the right thing. We have to advocate for not just cost, but value. So high value care. And what do I mean by that? Somebody being in the intensive care unit with advanced Parkinson's and dementia and dying there, that is high cost care. That is not high value care. And in fact, we know that that type of care can be traumatic to that person, cause increased suffering, can be traumatic to their family. There's studies actually showing that family members of people who died in the hospital have increased healthcare costs themselves over the next year, possibly because of the stress of their loved one dying in a hospital environment. So that's high cost care, but it's not high value care. So we really need to think about what are the goals of the care that we're providing. We absolutely need to look about costs. And again, the United States is kind of an outlier. The United States spends more money on healthcare than anyone else, and we get less for it than anyone else. Um, and every healthcare system has its own strengths and weaknesses. But I think it's important not just to look at how much things cost, but how much money we're saving. We need to think about how do we integrate palliative care from diagnosis through serious illness and end of life. And I think it's really important that we push for policy change, we push for education, and we push for resources to be able to do this high quality person-centered care. So what are the components of neuropalliative care? This is a quote from Dame Cicely Saunders, and she is really the founder of the modern palliative care movement. She started the first modern hospice in the United Kingdom in the 1960s, and she says, "You matter because you are you, and you matter to the end of your life. We will do all we can not only to help you die peacefully, but also to live until you die." And to me, this really gets at some of the things that are most important in palliative care. The first part, you matter because you are you, means that we need to see and hear and know you as a person to provide the best care possible. And that we need to not only help you to die peacefully, but also to live fully until you die. And we can't lose sight of either of those important goals. Serious illness communication is really the heart of palliative care. And it's one of the things when I'm training physicians on how to do palliative care that I probably spend more time on than almost anything else. And the parts of serious illness communication include how do I give bad news? And one of the things that's important with that is how do I give bad news in a way that is honest and clear? Sometimes physicians or other healthcare providers, in an attempt to kind of create a softer blow, will kind of whitewash the news. And they will end up talking in a way that's not totally clear. And what happens is that people often end up more confused than they are helped by it. And so, as a patient or as a family member, if you're not clear, not sure what your doctor is telling you, ask them a clarifying question. So, if you want to know, how is my illness going to progress over the next year, and they say, well, everybody's different, you could, respond, okay, I understand that everyone's different, but what is the best case scenario for how I will do? What's the worst case? What's the most likely case? Will I still be able to work in a year? So you can ask clarifying questions that help your doctor to be a better doctor and a better communicator. It's important that doctors ask you about your values and what's most important to you, but you can tell them these things if they don't know. So you may need to tell a doctor that, if I'm getting close to the end of my life, I don't want to spend a lot of time in hospitals, or I don't like taking medications. Working with difficult emotions, something again we spend time on, but for you, you can say, this is very upsetting information to me. Is there anyone on your team who can provide me with more support? Again, these are things currently that aren't always automatic for doctors, but if you come into the visit prepared and with a checklist, you may be able to drive the conversation in a way that's going to benefit you more. Other things that are important are what's called advanced care planning. So these are oftentimes putting in writing things that are important to you as things move forward, but it also ties into this idea of having a roadmap and having some anticipatory guidance about how things will play out in the future. Getting support for family members, addressing non-motor symptoms, attending to psychosocial and spiritual issues. And again, when we think about these things from a patient or a family perspective, these are things that you can come into a visit with a checklist. An example of this is pain. A lot of neurologists don't routinely ask about pain, but if you tell them that you are having pain and you want it addressed, they can address it for you. So sometimes you have to be an activated or a proactive patient or family member in order to get the care that you need. I've recently been thinking about this idea of positive medicine, this idea of how do we live well and live fully until you die, not just surviving. Part of this as healthcare providers, as patients, as care partners is resiliency and self-care. Part of it is restoring a sense of choice and control. One of the questions that I learned from a chaplain who I worked with is asking people, how do you hope to grow through this illness? And I love that question because it really gets to the fact that even though there are things outside of our control, no one ever chose to get Parkinson's or to have a loved one with Parkinson's. We do have a choice of what we do with that. And are we going to continue to grow as a person? Are there ways that we can get stronger? Are there ways that we can learn grace? Are there ways that we can inspire those around us? And as long as we're alive, are there opportunities for joy, for love, for meaning? And to not lose sight of those things. So we may not be able to control how much time we have, but we can control what we do with that time. I see patients with all kinds of illnesses, including brain cancer and Lou Gehrig's disease, ALS. And when I see people with those illnesses, if I know somebody has 6 months or a year to live, my question is going to be, how can I make this 6 months or year the most meaningful year of their life, rather than the most meaningless year where they're in and out of the hospital? So kind of reframing things in a way that's positive, even though there are things clearly that are negative about it. So this is the idea of, helping your healthcare provider. So bringing in a checklist with things you want to cover. These could be non-motor symptoms, psychiatric symptoms, emotional or spiritual issues. Even though it's not ideal, you can be the person who starts these important conversations. You can be courageous and brave enough to ask your healthcare provider, how is this going to play out over time? And you can let them know, I'm strong enough to hear it. I think sometimes healthcare providers are paternalistic and may whitewash things or hold things back because they don't want to destroy hope, but you can let them know that they can be honest with you. You can share with providers the things that are most important to you, that it's very important to me that I have an opportunity to die at home. It's very important to me that I get an opportunity to have a family reunion with my family in the United States or in Italy. And so maybe not, letting me know, how much longer can I travel so that I make sure that I don't have regrets at the end of the day about things that I didn't do. And letting, providers know your preferences for care. And some of the qualitative work that I've done, patients have told me that I don't always tell my doctor what's going on because I'm afraid that if I tell him something, he's going to start me on a new prescription. And there's an opportunity there to let your doctor know that, hey, my nose itches, and no, I don't want another medicine for it. If you have other things to offer me, great, but otherwise, this is just for your information. And the last couple parts of the talk is kind of bringing this into action. So how do we connect to this neuropalliative care philosophy? This is a quote from John Kabat-Zinn, who is a Buddhist and has written a great program called Full Catastrophe Living that allows people living with serious illness to use mindfulness to have a better quality of life. And this quote says, extending the reach of our own heart lets us live in the world in ways that embody greater wisdom and compassion, loving kindness and equanimity, and ultimately the joy inherent in being alive. And to me, I really feel that neuropalliative care and palliative care allows us to deliver on this promise. So tying palliative care to values. So some values that people may have is to be comfortable, to spend time at home with family, to make time for joy, meaning, spiritual concerns, to be seen and heard by my healthcare team, to have tough conversations now, to make it easier for yourself and your family later, to be a role model to people around you with grace and courage and wisdom. So these are things that as a patient or as a family member that you might tie palliative care and what we've talked about in this talk to your own personal values and your own personal journey. There are certainly other opportunities for palliative care. There's a large need for more research on palliative care and to try to move the needle and to really make this a new standard. I'm really happy that Isabel invited me to talk today. I think support groups and education is important. We need novel care models, education. So there's a lot of opportunities to spread palliative care if this is something that you think is important and that you believe in. So how do we move forward to integrate neuropalliative care into practice and make this a standard of care? As it says here, to know and not act is not to know. We are starting, and actually we have another grant in place that would expand this to international centers of excellence, including in Italy, to make Parkinson's palliative care a new standard for the Parkinson's Foundation Center of Excellence. And I think if this project is successful, that palliative care will not only catch up to where it is in cancer, but actually exceed it. So we got a large grant to make palliative care standard across the Parkinson's Foundation Center of Excellence network. And what we're going to do, and what we are doing right now, is talking to various centers, learning what they are currently doing, learning what the barriers are, what the opportunities are, and creating plans. And we're creating 5 pillars of palliative care that we can measure and that we can act upon, including non-motor symptom management, advanced care planning, psychosocial and caregiver support, and specialist palliative care. And then we're providing training and coaching to get centers of excellence up to a very high level. These again are the 5 pillars that we are trying to get all Parkinson's centers to do. So this is what we want to see over the next 3 to 5 to 10 years to be the new standard of care for Parkinson's. And so that if somebody with Parkinson's sees a Parkinson's specialist, that they can expect to receive these things, that they'll get a good roadmap, that their care partner will be supported, that non-motor symptoms like pain will be addressed, that psychosocial and spiritual issues will be addressed, and that specialist palliative care or hospice towards end of life will be applied early and in a timely fashion. As part of this grant, we also got an enhancement. So we got an extra grant to try to understand how COVID affects our plan. So when I wrote this grant, which was over a year ago, actually it was 2 years ago, we didn't have COVID. And so at that time, as I was imagining the grant, telemedicine or televideo visits wasn't a thing. COVID wasn't a thing. Global pandemics weren't a thing. And COVID certainly has changed a lot in our world. One of the things that I think is maybe, you might say a benefit is that I think COVID has convinced a lot of people that palliative care is very important. And I think a lot of hospitals and hospital systems really appreciated and really put more resources behind palliative care during the COVID pandemic because they were having to deal with situations that they had never came across before. And so as part of our COVID enhancement, we are integrating telemedicine into our plan. And we're thinking about how COVID has affected not just patients, but also affected care partners. I think one of the groups that's been most disproportionately affected by COVID has been family care partners whose isolation is made worse. Social services are harder to get. And so that's something that we're very conscious and conscientious of as we're moving forward. So to summarize, and we're ending right around 10 minutes in advance, so we'll have time for questions. Neuropalliative care aims to improve quality of life for people living with neurologic illness, including Parkinson's. So that is, in a nutshell, the goal of palliative care. Palliative care needs, such as spending time with family, symptoms, psychosocial issues, are important drivers of quality of life, and these are not well met under current models of care. And so I think we can safely say that palliative care works and that palliative care is essential to improve outcomes for people living with this illness. Neurologists can improve outcomes for their patients through palliative care communication tools and other skills. And I would say, add to that, that neurology patients and family can improve outcomes for themselves by asking their doctors to do these things. Neuropalliative care can enhance your life, can find opportunities for better quality of life with any serious illness. And to get neuropalliative care when you need it, you have to ask for it, you have to get it, you have to do it. And so this is not something, I think we all play a role, physicians, patients, healthcare systems, support groups, in terms of advancing this agenda. And so with that, let me stop sharing and we will turn things over for questions.
Yeah, I see that there are a lot of questions in the chat. Let's start with the first one. Let me get up there. So, hope that you will address this question. I would like to know what organizations are addressing the death with humanity choices of those with neurological conditions. Currently, my understanding is it's not accepted in the most of the areas.
Yeah, that is going to vary kind of state by state and country by country. I don't know, maybe there's somebody in Italy who knows. You know, in the United States, there's a group, Compassionate Choices. There are other groups with Death with Dignity. There's a physician group on medical aid and dying. And so there are a lot of opportunities, a lot of ways that people can get involved if they want to advocate for, you know, what's been termed deaths with dignity or allowing people easier access to medical aid and dying or euthanasia. So definitely an area where people can advocate. In fact, in Colorado, where I worked a year ago, the medical aid and dying law there was actually put forward and that got passed into law by somebody with Parkinson's. So this is absolutely an area where I think patient and family advocates can make a difference.
Mm-hmm. The next question, how is this used with residents in assisted living?
Yeah, it's a great question. So with assisted living and with nursing homes, yeah, I think there's an opportunity there. And I think actually, again, that COVID has made it in some ways easier to give that care. So I have been doing a lot of virtual visits to people living in assisted living and living in nursing homes. And I think this whole approach and framework, you know, if anything, becomes more important for somebody in a nursing home. So we still want to address their Parkinson's disease with skill and compassion, but I think we also need to address isolation. We need to advocate for that person to make sure that they have opportunities for joy and connection. We need to recognize that just because somebody is no longer living at home doesn't mean that that person's family and care partner may not still worry a lot and suffer. And so, yeah, I think it's important that we, you know, integrate this, you know, whether people are living at home, whether they're in a hospital and hospice, assisted living or nursing home, that this is, you know, kind of essential care no matter where you are.
Mm-hmm. The next question, palliative care gives strong personality. Which are in details most strong effects of Parkinson's? I'm not really sure what he means with it.
Yeah, no.
See, okay, good. I'm a foreigner myself, but I have problems with this one too. Okay, let's see. How would you define this from just good clinic care?
Yeah, that one I can address. I mean, that has come up a lot. Actually, you know, particularly talking to physicians, is sometimes people will hear me talk about this and say, how is this any different than people just being good doctors? Shouldn't good doctors do all of these things? And I would say two things about that. One is that I think a lot of doctors, even doctors who haven't been trained in palliative care, some people do these things naturally. Some people do these things better than others. So this is absolutely part of good care. But I think it's also important that we have a framework for it, and that we have words for it. So if we just call this good care, I think it's very easy for things to kind of fall between the cracks. It's also very easy to make it hard to measure. That if we're just calling this good care, I think actually all physicians, I think all physicians would agree that they are better than average. And that's, it sounds impossible, but I think all physicians believe that their communication skills are better than average. The care they provide is better than average. And so by naming palliative care and naming these specific skills and specific outcomes, we have things that we can hold people accountable to and to measure. And so this really goes beyond just good care. It's actually some very specific things. And I think it's important that we recognize that there are some very specific components here, that it's not just being a good doctor.
So you mentioned the future. How do you think Parkinson's disease care is going to change in the future?
Yeah, so when it comes to palliative care, my hope about that is that, and again, I don't know how this is in Italy, but in the United States, if you go to a cancer center, you will get a social worker, you will have a chaplain, you will have a book club, there'll be a summer camp for your children. You get this very comprehensive model of care. If you go to a Parkinson center, you don't get any of those things. And so my hope is that in the future that, Parkinson's, which in my opinion, I think in your opinion as well, is it's a serious illness. And it's something that affects people throughout, from diagnosis to advanced disease. And I think as a serious illness, we need to treat it as a serious illness, and that we need to support people, family, and patients living with this illness. And so my vision for the future, what I'm working towards, is to make care for people living with Parkinson's comprehensive and using this palliative framework.
What can be the role of meditation in improving the quality of life?
Yeah, a good question. So meditation has been studied actually with Parkinson's, with MS, and a few other illnesses. And I think it can be used to help with symptoms. I mentioned John Kabat-Zinn and full catastrophe living, or mindfulness-based stress reduction, but it can be used to help manage pain and fatigue. It can be used to help deal with uncertainty for the future. It can be used for care partners and family to be able to cope with things better and to build resilience. I think it can help people to be more flexible with dealing with some of the uncertainties and unpredictabilities when it comes to Parkinson's disease. So, for people who are interested and open to it, I think both physical exercise and mindfulness can be very important to improving quality of life.
Will the use of medical marijuana be a part of palliative care?
It can be, both in Colorado and New York. I've supported and I've given licenses for medical marijuana. The things that I mostly work with people on with it are pain, sleep, anxiety, nausea, appetite. There's not a lot of good research supporting its use for motor symptoms in Parkinson's. I have a few patients where it may smooth out motor fluctuations, but I haven't seen a lot, or really any people who have been able to get off of levodopa or be able to substitute medical marijuana for other traditional medications. But it can sometimes allow people to lower the dose. And for non-motor symptoms, it can certainly provide some relief.
Okay, I think. What do we have to?
And let me, actually, while we're waiting, let me also share my screen one last time. There was one slide that I had forgot to put up, just so that people have it. So there is a new International Neuropalliative Care Society. There is the website. If people want more information about things, they can join the society. We're going to be getting our membership off the ground soon. We're going to have our first meeting November 4th through 6th this year. It's going to be a virtual meeting. and patients and care partners are not only invited, but we're really encouraged to come. That we see people living with neurologic illness as really the experts on palliative care for neurologic illness. And so we want your voices, we want your eyes, we want your ears. So if people are moved by this, definitely sign up and get involved. And we, if you want to be part of a committee, you want to be more involved, definitely let us know. But this is certainly a very patient and family friendly organization.
Okay, I think we answered all questions. Let me see. Yeah, the holistic vision. This comes up again. Holistic approaches. I think you already answered this, right?
Yeah, and we can, just to emphasize that with palliative care, it is holistic. That we, talk about the total pain of illness. Meaning that we don't just look at medical symptoms or biomedical model, but also social, spiritual, emotional, and other contributors to suffering and to quality of life.
Okay. Good. I think in respect of your time and ours, it's 2:00. Thank you so much. And I just see we had 65 people from Italy on the other channel. That's wonderful. And I'd like to thank all our collaborations in Italy, Germany, the UK. I think it's fantastic, that COVID had something good. I think it brought the world a little bit closer together. So we meet every week. Thank you so much, Benzi, for your talk. I think it was very educating. And if anybody has any questions, you let me know, or I get you in contact, or you can sign up on the website, since I think this will be the future.
Isabel, I would like to ask: is expensive? It is a new way to. Because unfortunately in Italy there is not this mentality. So also I think in the other part of the world there is maybe we are afraid to talk about this palliative care, and so we postpone, and so the patients are afraid, the doctors are afraid, so and maybe it's also these are also expensive.
Yeah, that's true in the United States as well. I think every culture, I think that's actually one of the reasons we made this an international society, is that I think every culture has certain strengths and every culture has certain weaknesses when it comes to palliative care and whole person care and talking about things like death and dying. And so I hope we continue these conversations moving forward and that we learn from each other. But I absolutely believe you, and I think certain Catholicism and being in a very Catholic country certainly could influence how these conversations happen and viewpoints about it. So yeah, so I look forward to keeping this an international dialogue. But thanks for the comment.
So I know that you use also the music to a lot. Is important. The sound of the music is give more effect on the humor of also arrive to in our internal body, not only in our brain, but they make very quiet.
Yeah, music's important. I mean, that could be a whole other lecture on music and neurology and the importance of music in palliative care.
Okay.
All right, thanks.
Good. I think that's it is for today. Thank you so much, Benzi. Thank you so much for all the translators on the other side. We don't see them, but I think there was Andrea, there was Marcy, and there was one more. I forgot somebody, but thank you so much for translating. I think it's a great way to share informations, and I hope we can continue our conversations at another day.
That's good. Take care.
Thank you so much. Thank you. Really appreciate it.
Thanks a lot.
Thanks.